What are some of the main symptoms that somebody, or signs and symptoms that somebody has fatty liver?
Yeah. So unfortunately, some of the symptoms can overlap quite a bit with other things, right? So you're thinking about, you have a hard time losing weight. You've kind of tried everything. Um, you're fatigued for no sort of reason. Nothing really has changed. No stress levels have changed. No sleeping patterns have changed. If it gets really bad, some of the signs, you might actually start to see some of that jaundicey, that yellowing of the eyes
Mhm.
or what have you. You can get actually pain in the area from the inflammation that's being caused. But again, a lot of people don't know it, and these symptoms and signs sort of overlap with other things. And so usually how it's caught is on a blood test. When
Yeah.
somebody goes for, let's say, their normal yearly physical, and they run a complete metabolic panel. So you're going to have your liver enzymes in there, right? They're kind of checking out your your electrolytes in that panel. They'll check out your kidney function. They'll check out some heart stuff. If a lipid panel is run, but then they'll check out your liver, and that's where your liver enzymes are elevated. So if you think about it, in those specialized cells, these enzymes are working, and they're supposed to kind of stay in those specialized cells. But if the liver cells get damaged by fat or something else, those enzymes then will kind of trickle into our bloodstream, and it makes sense. So you get your blood drawn, and then those enzymes will be elevated in the blood, really understanding that there's something going on with the liver. And then it's up to the doctor to go, in medicine, there's called differential diagnosis. So why would this be? And so, of course, with a good intake, have you been increasing your alcohol intake? Have you traveled outside of the country? So there might be like a hepatitis or something going on. And so usually what follows that is an ultrasound. And that is where we see on the ultrasound, I mean, it can't be missed. That liver that's supposed to be just nice and kind of functional and, well, it's supposed to look like a liver. It looks like a big blob of fat. And then that's where the definitive diagnosis comes in.
Yeah. So is the fat kind of like almost like scar tissue there because the liver cells are becoming damaged? So they're spilling out their enzymes and their contents, and the fat almost is like coming in to take the place. Is that basically what's happening there?
I think that's a fair analogy. I really, really do.
Yeah.
It just, I mean, if you think about fat anywhere, it's in the way. It's completely
Mhm.
just in the way. And especially around an organ like that and inside those cells, it is very disruptive.
Yeah. Yeah, for sure. And so, one thing that I will tell people is if you have excess belly fat in general, like you should be able to look down, without bending your knees or anything and just be able to see your toes. If you have a protruding belly, okay, and you can't see your toes, most likely you're developing fatty liver. If you're not at the point where you're diagnosed yet, you are in the process of developing it. Now, that doesn't go across the board where, there are some individuals that are actually thin that are also developing a fatty liver. But we know if you have excess belly fat, you're in the process of developing it. So this is one of the reasons why metabolic health is such a key factor with this. And so that's one way, just right at home that you can be looking at it before you even get liver enzymes or before you get any sort of lab testing. Now, what are some of the key labs? You mentioned liver enzymes. What do you like to see? You know, Obviously they can be flagged high.
Hmm.
Is there like an optimal range when you're looking at blood work that you like to see the liver enzymes? I imagine you're talking about AST, ALT,
ALT,
alkaline
correct.
phosphatase, GGT, right? Is there an optimal range you like to see those in?
Yeah, well, first of all, I think this is a great point because I come across this a lot in my clinical practice. Different labs in different regions have different ranges. And so
Mhm.
sometimes it's difficult, right? But in reference range labs, you're going to have a range. And it's going to be, from like zero to something. What I usually like to do, if it's zero and we want it low, like the liver enzymes, I wouldn't cut 20% off that end, but I would cut 20% off the higher end. And so that's kind of just I like to see it more optimal.
Yeah.
Vitamin D is a good example of that, right?
Mhm.
There's so many people that walk into my clinic and they have lab tests in hand, and my doctor says everything is fine. And their vitamin D is like one click above rickets, right? So it's like, that range could be, let's say 34 to 100. They roll in at 35. Is that optimal? No, it's not. And so I like to take those ranges, 20% off that side, 20% off that side, and we're looking at more optimal. With those liver enzymes, we actually want them quite low because we want them to be inside, contained in those cells doing all of those various functions.
So what kind of range are you typically looking at? If somebody were to come into you, get some blood work done, where do you like to see the liver enzymes at?
Again, each lab. So if they're using LabCorp, Quest,
Okay. Yep.
Labs, it's all different. So it's tough to say because I don't want to mislead anybody. But when you look at that range, we want it more optimal. If it's high normal, we also need to understand with blood testing, it's very static, right? That needle is in somebody's arm for 20 seconds, maybe. And so, depending on the circumstances, that's just right then. It's a snapshot. But where are they going? If it's high normal, are they tending upwards?
Yeah.
And so that, or more optimal, I would treat that high normal as, hey, we should probably keep an eye on this and do some watchful waiting. But there is something going on because it's normal as it relates to these ranges, but is it normal and healthy for you?
Yeah, for sure. I typically like to see them between 10 and 25, the AST, ALT, somewhere in that range, GGT, alkaline phosphates, totally different range. Usually you're looking at that somewhere between like 60 and 90 or somewhere around there. So you start to see all of them high, you start to know, hey, like there's some sort of damage going on here. And then there's some other markers too. Like I'll look at fasting insulin, especially when it comes to fatty liver.
Yep.
Because that's a big factor. Triglycerides, right? That's a big one.
Triglycerides. So yeah, triglycerides is a big one because if you think about it, three, glycerol, sugar. So 3 sugar molecules on a fatty acid backbone. Usually hand in hand when I'm looking at a fatty liver situation, I see that triglyceride being elevated. That fasting insulin, hemoglobin A1C too, right?
Yeah.
So that average blood sugar over the last 3 months, you can get an elevated glucose. But you could be, I've had elevated glucoses and I've been fasting for 15 hours.
Yeah.
Now, I happen to work out on that fast, right? I also drove through LA traffic on that fast.
Yeah.
So my body's sort of taking care of me. My brain's saying, there's nothing coming in. We should probably tell the liver to kick out some gluconeogenesis and
that's
stuff.
why I like that HOMA IR, right? Because you're taking the fasting glucose times fasting insulin divided by 425. So it's like you're taking into account because glucose might be high, but insulin's real low. It's not an issue, right? If glucose is high and insulin's high, then you have a problem.
Then you've got that insulin resistance. Yes.
Yeah.
That's a great point. You don't need me on the show. Why don't you just do this all by yourself?
No, I enjoy the conversation, so, and the banter that we have. Right. So, but yeah, obviously, looking at some of those factors, I think is key when it comes to lab work because a lot of times, people aren't going to go in for the biopsy, and it takes a while for those liver enzymes to get to the point where they're clinically high. You and I specialize in actually catching fatty liver while it's developing before you get the actual, disease process and you have to go through the biopsy and all that kind of stuff. Why don't we just catch it earlier? You know what I mean?
And think about it. There's a subset of the population that are children who are not going in for an annual physical, who are not having these things run. But why? So let's talk about the reasons why a fatty liver would happen. You mentioned one, obesity. That's certainly one of them.
Yeah.
Insulin resistance, right? So those cells get resistant to insulin. So that insulin is going to be high in the bloodstream because it's not doing its job and utilizing glucose and all of that stuff. But it's the high fat and especially high sugar diets, right? We think about fatty liver and it's like fat, alcohol, what have you, medications perhaps, but really, so NFLD, right? Non-alcoholic fatty liver disease. And so saturated fats, trans fats, refined sugars can all lead to, of course, obesity and insulin resistance, which we've been talking about. And then you also, too, metabolic syndrome, right? So a cluster of those conditions, high blood pressure, high blood sugar, excess fat, abnormal cholesterol, all of those things we start to see. And then the end result would be the fatty liver.